Good afternoon, everybody. Yeah. So indications for vitrectomy in post-PKIs are mainly retinal detachment, which are iatrogenic only in 2.1% cases to 4.7% lifetime risk, but it's most commonly traumatic. Vitreous hemorrhage, endophthalmitis, and nucleus drop after triple procedures, all of these can be complicated with suprachoroidal hemorrhage. So traumatic wound dehiscence is one of the most common causes of posterior segment complications with vitreous loss followed by vitreous hemorrhage and retinal detachment. The problems with VR procedures in post-PKIs are the graft failure and the graft rejection and poor post-operative results because sometimes they present late and have severe PVR. More often they are complicated with redetachment, hypotony and choroidal effusion, and they need multiple surgeries. So coming to the study, so these were the inclusion and the exclusion criteria. Eyes with PK and posterior segment complications were included and a minimum follow-up of 6 months was noted. Eyes which underwent combined PK or with temporary K-Pro-assisted PPV were excluded and follow-up of less than 6 months was not included. Preoperative data, so the best corrected visual acuity, intraocular pressures, slit lamp examination, indirect ophthalmoscopy, and B-scan wherever the posterior segment had no view was done. Coming to the surgical approach, all the patients were counseled thoroughly as suggested in the previous slide. And these patients had clear corneas in the beginning of surgery, but the graft mostly becomes hazy during the surgery, so the epithelium was debrided. Use of scleral band 240 as encirclage was done in all the cases of retinal detachment in the study. And we coated the endothelium with viscoelastic in AFK cases, and minimum manipulation was done in the anterior chamber. Posterior vitreous detachment with Kennicott was done, and close shaving of the vitreous base was done, and the ports were always closed because these eyes suffer hypotony quite a lot. So this is a small surgical video. A core vitrectomy is done, followed by Kennicott induction, and a PVD is induced. Complete removal of vitreous is done. Any star folds or any kind of PVR is segregated. All the breaks are cauterized. And close shaving of vitreous base is done. In cases where we had an epiretinal membrane, ILM peeling was done. Followed by a retinotomy and laser to all the breaks. So coming to the first case, he was a 41-year-old male with a history of PK in 98. Graft was clear till June 22. He had a trauma with fist in June 2022 with the expulsion of the crystalline lens, and the graft was dehiscence. Graft was resutured. He had a retinal detachment later on. So we underwent with a vitrectomy with oil in July 22, but his graft failed in January 2023, so we had done the regrafting. This is the B scan for the patient where we can see the RD. And a buccal 240 with the re-PPV with fluid air exchange, endolaser, and oil tamponade was done in March 2023. So at that time, we did not have the fundus camera. So this is the slit lamp imaging for the posterior segment. And we can see that the retina was attached in all the quadrants on first month post-operative. This is 6 months post-PPV. The graft is fairly clear, but it showed a deficit of about 960 cells in comparison to the pre-op condition. That pre-op condition is before the graft was taken up. So intraocular pressure was 12, and best corrected vision was 6/60 for this patient. This is at 6 months. We had the access to the fundus camera, and the vision was 6/60, which is maintained till now. Coming to the case number 2, this was a 60-year-old male with the graft melt. He had post-PK. Therapeutic penetrating keratoplasty was done. He developed endophthalmitis over the next 2 days. So we attempted with a core PPV, vitreous tap, and intravitreal vancomycin and ceftazidime. Second day post-op, the graft was fairly clear, and the retina was on. We did put a gas in this patient as I was scared of a retinal touch in an area, to which I did a laser. But he had a ERM, and the retina was fairly on. And there was a ERM, as I told earlier. So coming to the results, we had operated 12 eyes till now. 7 had retinal detachment, and 1 had RD with serous choroidals. 3 had a vitreous hemorrhage. 1 had a vitreous hemorrhage with hemorrhagic choroidal detachment. 1 patient was of endophthalmitis. Out of all these patients, 1 patient had a redetachment, case number 1. And the follow-up with us is of 12 months to 42 months. All patients at presentation had a visual acuity of hand movement or below. Mean logMAR visual acuity increased from 2.3 to 0.8 to 5 logMAR. And the post-op visual acuity ranged from counting maybe close to phase to 6/18. All the 12 patients had the retina attached on last follow-up. 7 patients had a post-op silicone oil and encirculated 240 bands. Graft was clear in 11 patients with 1 had a regrafting. Average endothelial cell loss was 884 plus minus 156 cells, and it was more so in aphakics. Traumatic mood dehiscence was the most common indication for vitrectomy. Retinal detachment was the most common complication, followed by vitreous hemorrhage. Early intervention is associated with a better outcome. Significant endothelial cell loss occurred in comparison to a normal timeline for the graft, but graft remained clear at last follow-up, suggesting good outcome of surgery. So PPV in these eyes with PKP provide good anatomical and functional outcome. These eyes are at a higher risk of a graft opacification, dehiscence, retinal detachment, phthisis, and atrophic bulbi. Need of multiple surgeries has to be explained to the patient, but vision can improve significantly in these patients after PPV. Thank you.
So average duration, please. Average duration of follow?
So we have some patients, minimum follow-up is of 12 months, but we included 6 months as our cutoff. But we have 12 months to 42 months, over 4 years now.
Okay. Yeah. So all your patients had history of trauma?
Yes, sir. All of them which were included in the study had the history of trauma.
And all had detachments after keratoplasty, or it was?
So they had detachment after trauma, sir.
After trauma. So after if both the corneal graft is now, dehiscence is there, and retinal detachment, do you do a 2-step procedure or a single step?
So in this study we did a 2-step procedure, but we have done a combined procedure as well. I don't think there is a difference in the kind of results in both of them. I think they behave almost the same. The endothelial cell loss is almost the same in these patients.
In your case one, the patient status was aphakic at the last follow-up.
Yes, sir.
The aphakic dislocation. A patient was aphakic with the silicone oil.
Yes, sir.
And there was no oil graft touch. How did you prevent that?
So luckily, in none of our patients we had a graft touch. When I put oil, I injected pilocarpine in all the patients to have a small pupil. But even with that, we cannot be sure that the oil can't come. Even with the posterior mesh sutures, or with that, the oil comes ahead. I've seen few patients in which the oil comes ahead. So there's nothing actually we can do really.
In the case 2 which you showed,
yes,
there was a corneal melt or corneal this thing, yes, and the POD2 had cornea was clear. So, how, I mean, did you do anything in the first procedure to wash away the corneal melt, or what did you do so that the cornea became?
So the whole AC was cleared. Okay. The therapeutic penetrating keratoplasty was done for this patient. On table it was not noted. The vitreous was clear at that time, but in next 2 to 3 days he developed the endophthalmitis.
Mean gap between keratoplasty and your vitrectomy?
Sir, it was from 3 days to, the mean gap was about 12 days, but it was from 3 days to 27 days.
Okay. And if you take that from mean day, time from trauma?
The mean time for trauma?
Trauma to your surgery, if you exclude the keratoplasty.
I have not noted that. But I'll do that now.
Because the detachment outcome depends on that rather than your gap from the keratoplasty.
Right, sir, right.
Agreed?
Agreed, sir.